Hi everybody! Good morning po sa lahat. It's me again, John. Anyway, I can't sleep so I decided to go live tonight. Anyway, it's 11:44 ng gabi dito sa akin. So most probably it's morning in the Philippines. Today is January 13, 2023. And I can't sleep. Actually, I slept a while ago. And galing ako ng night shift. So nakauwi ako siguro mga anong oras ba yan. But I slept sa hotel for a couple of hours and then mga siguro mga 2 hours. Then I started driving from Duluth back here in the city, sa Minneapolis, where I live. So it's a 2 hour, 30-minute drive. And then I did the laundry. Would you believe that? And then I fell asleep on the couch for a couple of hours. And now I cannot sleep. I cannot go back to sleep. So might as well, what do you call this? Might as well make this time productive. Anyway, good morning po sa Pilipinas. And I hope everybody is okay there. Okay. And by the way, sa mga hindi po nakakilala sa akin, my name is John Gilrica Fort. I'm a nurse. And then I'm doing coaching for the NCLEX. And I also do local board examination review. I've been doing this for 21 years. And then few years after I finished nursing, I took up another course, Bachelor of Science in Respiratory Therapy. So currently I'm here in the US. I work as a traveling nurse. And yun. So during my free time, I conduct classes or coaching for the NCLEX. And then syempre may mga estudyante tayo dati sa local board na nagre-request na magbigay ng update sa mga concept na nakalimutan nila. So I decided to have this concept tonight or this morning there in the Philippines. We'll talk about arterial blood gas analysis. Hold on, may comments tayo. Hi! Shoutout muna tayo kay Dark Uchiha. Hello. Ellen Bagtas. Okay. NCLEX Passer 2021. Oh, congratulations. So we'll talk about arterial blood gas analysis. Wala pang ayos, no? Pero importante yung explanation natin. Okay. So let's try to turn off this background music. Okay, guys. So we'll talk about arterial blood gas analysis. Shout out to Cairo Kiana or Siana. Okay, so if there's such thing as arterial blood gas analysis, there is also this what we call venous blood gas analysis or the VBG. Okay? So, syempre, anong difference nila? Of course, if it's arterial blood gas analysis, the specimen we use here is an arterial blood. If it is a venous blood gas analysis, of course, common sense will tell us the specimen we use here is a venous blood. Magkakaroon ba ng difference sa parameters ng mga values? Of course, there is. Okay, knowing that a venous blood is a blood rich in carbon dioxide and low in oxygen, of course, it's the other way around for arterial, right? Technically, pag arterial blood, that blood is actually rich in oxygen and low in your carbon dioxide. Okay, so arterial blood gas analysis is not new to us. Maybe you saw some respiratory therapists extract blood from the patient for this specific procedure, for this specific test. Now, your ABG analysis is important because this is one way for us to evaluate efficiency of perfusion, efficiency of gas exchange. Okay, perfusion, gas exchange. We're talking not only oxygen but also carbon dioxide. Okay, so in your arterial blood gas analysis, it will give you an overview how what's the current standing of the respiratory and the metabolic status of the patient. Okay, so there are certain parameters or values that you need to understand. Okay, hold on, let me share my screen, guys. I think this will be better pag ganito siya. Okay, share screen. Share. We'll do this one. Okay, and then Okay, I hope you can still see me. So we have here your arterial blood gas analysis, your ABG. Okay, so ABG, arterial blood gas analysis. So there are parameters or values that you need to remember. Okay, so we have here your pH. By the way, pH stands for potential hydrogen. Some book it's potential hydrogen, some book it's power of hydrogen. So when you say potential hydrogen or power of hydrogen, it talks about acidity or alkalinity of a substance, solution, or surface. Okay. So the normal blood pH, we're talking about the arterial area, it's 7.35 to 7.45. Okay. The mean is actually 7.40. Okay, so don't forget that this mean, the 7.40, is so helpful for us, to us nurses and to other medical practitioners, lalo if you want to evaluate full compensation. We will talk about that in a bit. Okay, if the pH is actually high, okay, if the pH is high, okay, you call that as your alkalosis. If the pH is low, not slow na mabagala, is low, you call that as your acidosis. By the way, in the hospital, I haven't heard nurses giving report or notifying doctors there's a low pH or high pH. We usually use the term acidosis or alkalosis. Okay, so when you say acidosis, there's a decrease in the pH. When you say alkalosis, there is an increase in the pH. Okay. Next is what we call your partial oxygen pressure. Okay, the partial oxygen pressure ranges from 80 to 100 millimeters mercury. Please do not confuse yourself with your O2 saturation measured by your pulse oximeter. Okay, your O2 sat ranges from 95 to 100. But if you're a COPDer, pag COPDer ka, of course your O2 sat is different. Okay, the normal O2 sat for COPDer is 90% and above, but normally it's 95 to 100. Now, your in your ABG, it measures the partial oxygen pressure. So we use the unit millimeters mercury. For your pulse oximetry, your O2 sat, we use the unit percentage. Okay? So the normal PO2 is 80 to 100. If the partial oxygen pressure is low, mababa, okay, we refer that as your hypoxemia. So there's a decrease in oxygen level in the blood. If the partial oxygen is high, okay, mataas, we call that condition as your hyperoxemia. Okay, hyperoxemia. Next is your partial, okay, carbon dioxide pressure. The normal partial carbon dioxide pressure ranges from 35, okay, to 45 millimeters mercury. Okay, if there is an increase in the partial carbon dioxide pressure, if there's too much carbon dioxide in the body, we call that condition as your hypercapnia. Hypercapnia. If there is a decrease in the partial carbon dioxide pressure, you call that as your hypocapnia. This is very simple. Okay, so hyper increase, hypo is low. As simple as that. Now, anyway, and of course, we have here your bicarbonate, your HCO3. Your bicarb ranges from 22 to 26. Okay, 22 to 26 milli equivalent per liter. Now, anyway, we know for the fact that bicarbonate is part of the buffer system. Okay, that's in your renal. Okay, the bicarbonate in nature is actually alkaline. Okay, so that is why if there's too much bicarbonate, too much bicarb, it can cause alkalosis. If there's a decrease in your bicarbonate, of course, if there is no bicarb, and I just said that bicarbonate is a form of alkaline, and if it is alkaline, technically it neutralizes acidity, correct? So if there is no bicarb, if nobody neutralizes acidity, so patient will end up having acidosis. So this will result to acidosis. Okay? So ito yung mga magiging effects nila. Okay? So I hope naintindihan niyo yon. Anyway, so in order for you to have, sabi nga natin, in order for you to have arterial blood gas analyzed or analysis, you need to have a specimen. Okay, the specimen for this is an arterial blood. And usually, gaano ba karami yung arterial blood na kailangan natin for this type of test? 1 ml is enough. 1 ml of arterial blood is enough. But usually when we extract blood from the patient, we get as high as 3 ml. Okay, 3 ml. Bakit? Para kung mag-error yung machine, meron ka pang another ml na gamitin as a specimen. Okay, so we always have an extra specimen to run the test. Okay, now what is so important about this specimen is that when you extract this from the patient, you need to send it immediately to the laboratory, because any delay, okay, any delay with the test, pag nahimulay yung blood, it will also alter the result. There are a lot of conditions or factors that will affect the ABG result. Okay, number one is if during the blood extraction, when you get specimen from the patient, if your patient is currently receiving O2 supplement, it will also affect the ABG result. That is why part of your nursing responsibility is to make it sure to note that the time when you took the blood from the patient is receiving O2 supplement. You have to indicate how many liters per minute the patient is receiving, what is the type of oxygen interface the patient is using. Is the patient using a high flow or a low flow? Okay, is the patient using a heated high flow, a simple face mask, a Venturi mask? You have to indicate that. Okay, kung nakasipa pa siya, naka-BiPAP pa siya, okay, you have to indicate that, because again, O2 supplementation will affect, of course, the ABG result. Another thing that una sabi natin is if there's a delay. Okay, number two, if the patient tested for ABG is currently receiving O2 supplement. Third is heparin. Normally kasi yung ginagamit natin na syringe when you get blood or extract blood from the patient is heparinized. Now, may mga facilities po may mga ibang facilities na wala silang heparinized syringe. So we will transform an ordinary syringe to heparinized syringe. So if you put too much heparin in the syringe, it will also affect the ABG result of the patient. So there's a lot of what do you call this, conditions that will affect the test. Okay. Now, prior to blood extraction, there's a test you need to perform, and that is what we call the Allen's test. Okay, so what is the purpose of your Allen's test? The purpose of your Allen's test is to check collateral blood flow or circulation to the hand. Because remember, ang common po na site for ABG analysis is when you puncture the radial artery. By the way, this is my left hand, so the area here is where you can find the radial artery. So the radial artery is on this side. Here is the ulnar artery. So when we do Allen's test, if you have time, you can search this on YouTube, or you can read the book, how the Allen's test is being performed. But technically, what we do is we include these arteries, and then we release the other one, and you have to make sure na yung perfusion bumalik yung what do you call this, normal skin color when you release the occluded artery, and do the same sa other artery, sa ulnar, and then ulnar radial and then ulnar. So the purpose of doing that is to evaluate collateral circulation, so that we know that if we puncture the radial artery and there's something wrong there, may complication, you won't have a not hard time, you won't be threatened that the circulation is impaired because the other artery can compensate. Okay, that is your Allen's test. So there are things you need to remember about your ABG. Isa-isahin natin yung mga parameters na to, yung mga dapat tandaan sa examination. And after this, I will teach you how to read ABG. Okay? So it will be a step-by-step how to read ABG. And I know that sometimes lumalabas ito sa qualifying exam, not only in the NCLEX RN, sometimes lumalabas ito sa local board examination in the Philippines, sometimes in HAAD, DHA Prometric. Okay, so let's begin with your pH. By the way, when I said this, the pH or potential hydrogen talks about acidity, alkalinity of a substance, solution, or surface. Now, guess what? There are two systems in the body that will affect or regulate pH. Okay, so what are two systems, or let's to be specific, what are two structures or organs in the body that will regulate or affect pH? Okay, number one is of course your respite. Okay, your respiratory system, your lungs to be specific, will affect the pH. Okay, number two, of course, the kidneys. Okay, renal. Okay, remember the renal or the kidney specifically, it has two basic functions. Okay, what are the two basic functions of the kidneys? Your kidneys has is what we call non-excretory and excretory functions. So when you say excretory functions of the kidneys, it talks about eliminating waste products, eliminating too much water, eliminating too much hydrogen. That those are actually excretory functions. When you say non-excretory functions of the kidneys, it talks about the kidneys will help synthesize vitamin D. Your kidneys will help with what do you call this, blood production. Remember, the kidneys will produce a hormone called erythropoietin. So don't be surprised that the patient with kidney problem, one manifestation is that they have or they will end up having anemia. Okay? Kaya nga kung may mga kidney problem ka because of erythropoietin hormone issue, doctors may recommend Eprex or Epogen, okay, which is a form of an erythropoietin derivative. Okay, so that's your pH. Again, there are two systems. You have your respiratory system and then you have your urinary system. Okay, and I said increased pH is alkalosis, a decrease in the pH is acidosis. Okay, next is of course your oxygen. Okay, um, a decrease in the oxygen is your hypoxemia. An increase in the oxygen is hyperoxemia. And please be reminded, if you go to high altitude places, yung mga high altitude areas, okay, it has a low O2 concentration. That is why we discourage patients with polycythemia vera to go to high altitude areas because it will stimulate increased RBC production because masyadong mababa yung O2 saturation sa environment in a high altitude area. So, ang tanong, what is the normal saturation of oxygen ba sa environment, in the atmosphere? About 21%. Okay? So, in a high altitude area, there is a low O2. So, the body needs to compensate with that. So, as a result, there will be increase in your RBC production. Okay? So, anyway, oxygen is simple. Next, let's talk about carbon dioxide. Okay, mabilisan lang to na overview ha. So carbon dioxide is, sabi natin, an increase in carbon dioxide is hypercapnia. A decrease in your carbon dioxide is what we call hypocapnia. Okay? And by the way, between oxygen and carbon dioxide, tandaan, what is the primary stimuli for respiration? Okay? The primary stimuli for respiration, depende po yan, ano? If we're talking about COPD or we're talking about patient na normal. Okay, what I want to dwell more, okay, discuss more is a COPD patient. Okay, by the way, COPD is an old name. Okay, there's a new name for COPD. We call that as your CAL. CAL stands for chronic airway limitation or chronic airflow limitation. So if you're a COPD, your primary stimuli to breathe is actually hypoxia. So we call it your hypoxic drive. So pag bumababa yung oxygen level mo, it stimulates you to breathe. Okay? So that is why if you notice, most probably nabanggit ng mga lecturers natin, pag ang patient natin is COPD, we discourage you giving a high oxygen flow rate because it can cause suppression of your respiratory center. Mawawalan ka ng stimuli to breathe. Okay, and having said that, if a patient is a COPD, the best oxygen interface is your Venturi mask, correct? Now, why Venturi mask? Because Venturi mask, among the different devices, oxygen devices or oxygen interface, it is your Venturi mask that gives the most accurate oxygen concentration. Now, if you cannot find Venturi mask, the second answer will be your nasal cannula because it gives or it delivers a low oxygen flow rate. Okay? And I also mentioned bicarbonate a while ago. So bicarb is a form of alkaline. I said that. Now, what else? What else? Okay, let me clear the whiteboard. Hold on, let me check kung mga tanong tayo. Okay, Ava, kidney to eliminate. Okay. By the way, if you have any questions, just drop a message there and I will try to answer it. Let's go back. Okay. Okay, things to remember. Number one, okay, I hope you are familiar with what we call hypoventilation. Hypoventilation. Now, why do patient hypoventilate? What causes hypoventilation? There are a lot of factors. Okay, so patient may hypoventilate because first you have to understand what is part of the brain that regulates breathing, that regulates respiration. Isn't it? It's your medulla oblongata, correct? Some will say medulla, some would say medulla, whatever. I don't care how you say it. We know it's medulla or medulla oblongata. Maybe some of you will answer pons. Pons will help regulate respiration, but it is your medulla considered to be the respiratory center. So any depression in your medulla oblongata may be related to trauma or related to infection, related to bleeding, any instance or condition that can cause injury in the medulla oblongata, injury in the pons, okay, that will affect breathing pattern, that will affect ventilation, okay, it may that can cause hypoventilation, okay. Another condition that can cause hypoventilation is a patient having neuromuscular conditions. Now, if you notice a patient with neuromuscular problem, motor deficit, the usual complication or cause of death is respiratory failure. Now, what can you give me an example, Sir John, of a condition said to be neuromuscular in nature, yung mga motor deficits? Example, uh, Parkinson's disease. Okay, Parkinson's disease is a degenerative problem. Okay, that by definition of the textbook, ano ba yung Parkinson's disease? Parkinson's disease is a slowly progressive neurologic movement disorder. Okay? So it is degenerative type. Okay? Brought about by a decrease in the level of your dopamine. Okay? So remember, dopamine is both inhibitory and excitatory. Okay? So dopamine is actually inhibitory to your muscles. Okay? Yeah, inhibitory to your muscles because acetylcholine is excitatory to your muscles. Okay? So inhibitory to your muscles. Why? The exact cause of your Parkinson's disease, why there's a decrease in the dopamine is unknown, but attributed to uh, decrease or damage in the substantia nigra cells. Okay? Number two, another neuromuscular problem, Guillain-Barré syndrome. Okay, which is a form of demyelinative disorder. Or another example is your multiple sclerosis, which is another form of demyelinative disorder. Another example of a neuromuscular problem will be your uh, myasthenia gravis, right? In myasthenia gravis, it affects the myoneural junction of the patient because of production of antibodies that will destroy your acetylcholine. So they will affect motor functioning of a patient. Not only that, another example is motor neural problem. I hope you can still remember this. Ano tawag doon? Um, I hope you can still remember the ice bucket challenge. You call that disease as ALS, amyotrophic lateral sclerosis, or your Lou Gehrig's disease. Okay, it's also a form of a motor problem. So they will all end up with the complication na respiratory. Okay, eventually patient will die out of respiratory failure, respiratory problem. Okay, so that's one cause. So what's the problem when you hypoventilate? The problem with hypoventilation is that if you don't breathe, if there is impaired ventilation, okay, so that will result to decrease carbon dioxide elimination. That will lead to decreased carbon dioxide elimination. So the carbon dioxide cannot get out. So as a result, carbon dioxide in the body stays. So that will be increased carbon dioxide retention. And this increased carbon dioxide retention will increase your carbon dioxide level. We call that as your, of course, hypercapnia. And guess what? Too much carbon dioxide in the body will decrease your pH, and we call that as your acidosis. So what type of acidosis is this? This is a form of respiratory in nature because the underlying cause is ventilation problem. So this is a form of respiratory acidosis. So don't forget this, hypoventilation can cause respiratory acidosis. Why? Because when you hypoventilate, carbon dioxide cannot get out, carbon dioxide stays in the body, okay, bumping your carbon dioxide level, decreasing your blood pH. Okay, so that result to respiratory acidosis. So the main problem with your hypoventilation is there's too much carbon dioxide. So as a nurse, what are possible actions that can we do that will promote carbon dioxide loss? Will you tell the patient to breathe to your brown paper bag? No, because doing that will promote carbon dioxide retention because you're breathing in again. You're expelled carbon dioxide. So we do not tell the patient to breathe in a paper bag. So what we do here is to tell the patient an activity or an action that will promote carbon dioxide loss. And what is that? per sleep method of breathing. So when you say per sleep method of breathing, it's just like blowing a candle. For example, this is a candle. You blow a candle. So if you blow a candle, there's a prolonged expiratory time. Expiratory time. Nabubulol ako. There is a prolonged expiratory time. Okay, that increased expiratory period will promote carbon dioxide loss. Okay, so this is your per sleep method of breathing. Okay, so that is your hypoventilation. Okay, next, if there's such thing as hypoventilation, may tinatawag din tayong hyperventilation. Hyperventilation. So when you hyperventilate, call this as your cosmos breathing or cosmos respiration. So when you hyperventilate, because you're anxious, you're in panic attack, okay? Naalala ko to, may pasyente ako the other day, nag-panic attack. Okay, anyway. So hyperventilation. So when you hyperventilate, gumagano ka, hyperventilate ka. So that will lead to increase in your carbon dioxide elimination, right? So if there's increased carbon dioxide elimination, of course, that will decrease carbon dioxide retention. You just have to reverse the problem. So this will lead to decreased carbon dioxide retention, leading to decreased carbon dioxide in the body, referred as your hypocapnia. Correct? A decrease in the carbon dioxide will increase the blood pH. We call that as your alkalosis. Correct? Okay? So when you hyperventilate, it can cause respiratory alkalosis. So the main problem with your hyperventilation is that there is hypocapnia. There's a decreased carbon dioxide in the body. So what will be your responsibility as a nurse to bring back or to restore carbon dioxide? So nabanggit na natin kanina, okay, tell the patient to breathe sa paper bag. Okay? Naalala ko dati yung mga old pa na mga questions sa nursing qualifying examination, brown paper bag. Naka-specify talaga na brown, ano. Pero may mga bago tayo ngayon, tell the patient to breathe sa cup hands. Breathing through cup hands, through cup hands will of course restore carbon dioxide. So what else? We can also give anxiolytic medication, especially pag yung pasyente natin anxious, gaya ng nabanggit natin kung may mga conditions that can cause hypoventilation, may mga factors or conditions that can cause hyperventilation. Example, if you have fever, okay? If you have fever, if you have infection, it can cause hyperventilation. What else? Another condition that can cause hyperventilation is a patient having what do you call this? Metabolic acidosis. Now, give me an example of metabolic acidosis. Example is your DKA. Your diabetic ketoacidosis is a form of metabolic acidosis. By the way, your DKA is a complication of diabetes mellitus na common to patient with type 1 diabetes mellitus. Okay? Now, in your metabolic acidosis, there's a decrease in the blood pH. So, pag bumababa ang blood pH, alam mo, ganito kasi yan, your respiratory and your renal, they work hand in hand. Okay? So, kung may problema ka sa metabolic, the respiratory will try to help. Okay? If you have a problem with your respiratory, the renal will help. So, if you have a metabolic problem, okay, may metabolic acidosis ka, pag acidotic ka, mababa yung pH. So, ang gagawin mo, you hyperventilate. So, hyperventilation is a form of compensatory mechanism to your what? To your metabolic acidosis, to your DKA. Okay? Trying to cause hypocapnia to increase the blood pH because of the fact that you're acidotic. So which is a form of what we call feedback mechanism, which is a form of compensatory a reaction of the body. Okay? That's your hyperventilation. Before anything else, before I proceed to another topic, hyperventilation is also important, lalong-lalo na pag yung mga pasyente po natin na may increase intracranial pressure. So, ang tanong, sir, how can hyperventilation, okay, help patient with increased ICP? Okay, we will talk about that. So, intracranial pressure is a pressure exerted against the skull. Okay, the normal ICP is between 8 to 15. Some book less than 15. Okay, so to be safe, lagyan na natin less than 15 millimeters mercury. So do not confuse this with your IOP or intraocular pressure. That's for your eyes, which is about 10 to 21. Okay, millimeters mercury. So ICP is less than 15. Okay, now there are there are factors that will affect or influence intracranial pressure. Actually, there are three action. There are three elements or factors that will affect intracranial pressure. First is the CSF volume. Okay, your cerebrospinal fluid. Your CSF is a fluid that surrounds the brain and the spinal cord. It serves as a cushion, okay, protection of the brain and spinal cord. It is actually produced by choroid plexus. Okay, now the normal CSF is actually 100 to 150 ml. That's the range. If there's increase in the CSF volume, just like to a patient suffering from hydrocephalus, that would increase in intracranial pressure. Okay, that's your ICP. The second element or factor that will affect ICP is the blood volume. So, how many ml of blood is inside the brain? So, inside the brain, there's about 150 ml, 150 ml of blood. So, if there is ruptured cerebral artery, you had an accident, okay, trauma that leads to ruptured blood vessel, and then it causes bleeding intracranially. So that will increase the CK, the blood volume of more than 150 ml, and eventually that will increase the ICP of your patient. Okay, so that's the second factor. First is the CSF volume, second is the blood volume. The third and the last element that will affect your ICP is the brain mass or the brain volume. So, yung brain natin, kay gaano ba karami yung brain? Okay, ilang ml ba yung brain? Yung brain is about 1400 ml. So in short, that's 1400 ml. That's the brain. That's an average brain. But definitely magvavary din sa edad. Okay, pag bata, unit, iba. We're talking about adults, okay? Average. 1400 ml. So if there is a new growth in the brain because may tumubo na tumor, a new growth, a new plasm, okay? It doesn't matter whether it's a benign or a malignant, basta it's a tumor. There's a new tissue that grows inside the brain or inside the cranial area. So that will increase the brain mass, the brain volume of more than 1400. So that will increase the ICP of your patient. So those are three conditions that will affect intracranial pressure. Okay? So hindi lang tayo nag-discuss ng ABG, ano, nag-discuss din tayo ng mga nagsanga-sanga mga concept. Hold on, pa yung nagme-message sa akin. Sulit lang. Okay, what is this? May I miss your lecture? Kidney. Okay, let's proceed. Okay. Whiteboard. Balikan natin. So those are three elements or factors that will affect your ICP. Okay? And guess what? In your anatomy physiology, I don't know anong textbook gamit nyo. I don't know what textbook do you use when you were studying nursing for anatomy physiology. Back when I was still in college, we used the book of Marieb. Okay, I love the book of Marieb. There are a lot of authors for anatomy physiology, but personally, I like the presentation of Marieb. Okay, in the book of Marieb, we also have Tortora Grabowski. The book of Marieb, there's a statement there about ICP, about these three elements, that if one element is high, the other elements will compensate. Okay, we call that as your Monroe-Kelly doctrine or Monroe-Kelly hypothesis. Okay, Monroe-Kelly doctrine or Monroe-Kelly hypothesis. It states that if one element, okay, is affected, the other elements will compensate. Okay, so they work hand in hand. Now let's go back. How can hyperventilation affect, okay, or do good to patient with increased ICP? Here's the effect. If you hyperventilate, okay, if you hyperventilate, it causes hypocapnia, right? You try to check the thing I wrote sa whiteboard. It causes hypocapnia. Here's the catch. When there is hypocapnia, okay, lagyan natin dito. When there's hypocapnia, magkakaroon siya ng three effects. So what are three effects of your hypocapnia? Hypocapnia can cause cerebral vasoconstriction. Oh, it can cause peripheral vasoconstriction. And last, it causes pulmonary vasodilation. Okay? So don't forget this. When you hyperventilate and it causes hypocapnia or decrease in the carbon dioxide in the body, in the blood vessels in the brain constrict. So there's cerebral vasoconstriction. The blood vessels in the peripheral area will constrict. There's peripheral vasoconstriction. But the blood vessels in the lungs will dilate. there will be pulmonary vasodilation. So focus in the cranial area. I said there is cerebral vasoconstriction. When the blood vessels constrict, that will affect blood flow, correct? So that will decrease the blood that gets inside the brain, that will decrease the blood volume. Normally, it's 150 ml. So there's a decrease in the blood volume that will help decrease the ICP of your patient. Okay, so that's the reason why hyperventilation is helpful to patient with increased ICP. And take note, especially on the first 24 hours. Okay, especially on the first 24 hours. But of course, there are also other ways or means or management how to decrease ICP of your patient. We have medications. Okay, we can give osmotic diuretic. We can give what do you call this? We can give anti-inflammatory drug. Okay, we can give what else? We can give diuretics to your patient. I just said that. Okay, so there are a lot of parameters. May mga preventive measures pa tayo. We can give stool softeners. We can give anticonvulsants because if there's increased ICP, that will cause sensory, motor, combination, okay, deficits. So it will give you several neurologic manifestations, and one there is your seizures or convulsions. So that's why we give anticonvulsants. Anyway, so that's your hyperventilation. So tanong, what's the relationship now of your what's the relationship now of your ano, nabubulol ako. What's the relationship now of your carbon dioxide and your pH? If you try to check. Pag tumataas yung carbon dioxide, there's too much carbon dioxide in the body, the pH drops. Okay? If there's a decrease in the carbon dioxide in the body, the pH rises. So what's the relationship? The relationship is opposite. Okay, bro, opposite. That is why if you can still remember, you have this mnemonic, Rome. Okay, Rome. But the mnemonic Rome is kind of old. Okay, old. So I formulated another mnemonic. I call it Romeo. Romeo. Rome is old. I don't know who authored that, but I authored Romeo. Okay, so what's Romeo? So respiratory opposite. Okay, respiratory opposite. In short, the relationship of carbon dioxide and pH, they're opposite. If there's too much carbon dioxide, the pH drops. If there's a decrease in the carbon dioxide, the pH increases. So they're opposite. That's respiratory opposite, meho. Metabolic equal hydrogen opposite. So that stands, okay, that is why dinagdagan ko yung HO, ho. Yung alam ng common sa inyo is Rome. Respiratory opposite, metabolic equal, hydrogen opposite. Okay? So we're done with RO. Let's proceed with ME. Okay, here. Let's begin with vomiting. Vomiting. So when you vomit, okay, when you vomit, you throw up. When you throw up, or we call this emesis. Naalala ko dati. When I was giving handoff report to a nurse here in the US, I told her the patient had an emesis. What do you mean emesis? It's not emesis, and I was corrected. It's emesis. Taray, ano, akala natin alam natin yung mga spelling, pero yung pagbigkas pronunciation iba. So at least mabait sila. Alam naman nila na English is not our mother tongue. So they're very understanding. So we call that emesis. So when you vomit, when you throw up, when you had an emesis, you lose hydrochloric acid. Okay? So it's not only vomiting. If you have this frequent gastric suctioning. Okay? So not only vomiting, frequent gastric suctioning, okay, or a patient on the first and second trimester of pregnancy, if they have hyperemesis gravidarum, diba? Common yan sa first and second trimester. Pag suka ka ng suka, ano mangyayari? So if you vomit a lot, there will be increase in your gastric juice, okay, elimination, okay, or increased gastric juice loses. Okay, and part ng gastric juice is, of course, your hydrochloric acid. By the way, what specific cell produces hydrochloric acid? What cell in the stomach produces hydrochloric acid? If you can still remember. Let me check your comments. Let me see. What cell What cell? Oh, there's an answer. Jonalyn answered Monroe Kelly. Yeah, correct. By the way, the spelling of Kelly is Kellie. Kellie. I'm not sure if it's double L or one L, but I know it's Lie or Lli. Now tell me, what specific cell in the stomach produces hydrochloric acid? I need some water. I'll be right back. Kuha lang ako ng tubig. Let's have this background music before. Kuha muna tayo ng tubig. Okay, correct. Very good. It's parietal cell. Very good. How do you say your name? HTE nudge obrigado. Correct. John, it's your parietal cells. Parietal cells are cells in the stomach that will produce hydrochloric acid. Okay. What specific part of the stomach where you can find a lot of parietal cells? Now, if you can remember, if this is your stomach, may fundus, may body, may antrum. Correct? Na ako na lang para mas madali. It's part of the antrum. Okay? The antrum is part of the stomach that contains a lot of parietal cells. And by the way, your parietal cells are cells that will produce hydrochloric acid. And don't forget this, it will also produce intrinsic factor. And intrinsic factor is important for your vitamin B12 absorption. Okay? If you don't have that, it can result to anemia. And that anemia is what we call pernicious anemia. Let's go back. Okay, where is that? So if there's increased gastric juice elimination, nawawalan ka ng acid, nawawalan ka ng acid, tataas yung pH mo and that will result to alkalosis. Suka ka ng suka. Because again, I said this gastric juice contains acid. Okay? Next, diarrhea. You know diarrhea? Diarrhea. Diarrhea. Can I erase this? Burahin natin ito. Okay, diarrhea. If you have diarrhea, of course, there's fluid loss. Kasi mawawalan ka ng tubig. So there's increase in your fluid loss. Okay, correct? So what will happen if there's increased fluid loss? Kasi nga, may diarrhea ka, nagtatay ka. So if there's increased fluid loss, what will happen to your hydrogen concentration? Will there be increase or decrease hydrogen concentration? I want to see your answer. Tell me, what will happen to your hydrogen concentration if there's fluid loss? Will there be increase or decrease hydrogen concentration? End of the message. Hold on. Oh, Darlene said, thank you for the free review, sir. No problem. Okay, tell me, if there is increased fluid loss, you become dehydrated, what will happen to hydrogen concentration, high or low? Ako na lang. Thank you so much, Mr. Ricafort. There will be an increase in your hydrogen concentration. Okay? Magiging concentrated siya kasi nawawalan ka ng tubig. So, pag nawawalan ka ng tubig, yung blood nagiging concentrated, no chirocana. The correct answer is increase hydrogen concentration. Okay? So, increased fluid loss, increased fluid loss will result to increase hydrogen concentration because if you lose water, that makes the blood concentrated, right? No water will make the blood concentrated. So that will make the hydrogen concentration increase. And what will happen in there if the hydrogen concentration increases? If hydrogen concentration increases, that will bring down the pH, and we call that as acidosis. Okay? Acidosis. So a patient with diarrhea will end up having metabolic acidosis. Why? Because in diarrhea, there is increased fluid loss, and fluid loss will make the hydrogen more concentrated. Okay? More concentrated. If you vomit, you lose hydrochloric acid. If you lose acid, that will turn you to become alkalotic. Okay? So again, what is the relationship now? Okay? In your metabolic, they're opposite. Okay? They're opposite. So not opposite, equal. Okay? It's your respiratory that is opposite, metabolic that's your equal. And of course, HO, hydrogen opposite. Look, HO is hydrogen opposite. Increased hydrogen concentration will bring down the pH. This is the reason why a patient with renal failure end up having metabolic acidosis. Tell me why. Why patient with renal failure end up having metabolic acidosis? Because in renal failure, there is decreased hydrogen elimination. Remember, if you have renal dysfunction, it will affect eliminate excretory function of the kidney. Correct? That is why if the kidneys cannot eliminate waste products, okay, cannot eliminate hydrogen, decreased hydrogen elimination will result to increase hydrogen retention. If there's too much hydrogen in the body, that increases hydrogen concentration. Concentration. Wrong spelling. Concentration. If there's too much hydrogen in the body, that increases hydrogen concentration, that will bring down the pH of the patient, resulting to acidosis. Okay? So patient with renal failure will end up having metabolic acidosis due to decreased hydrogen elimination, causing retention of hydrogen, increasing its concentration. Okay? So that's one reason. So that is why I corrected this, not actually corrected, I added actually, okay, the old mnemonic Rome, I added ho. So respiratory opposite, metabolic equal, hydrogen opposite. I hope this thing is clear. Let me see if you have any questions. You don't have any questions, so that's good. Hold on. Okay, let's proceed now. So the question here is, sir, can you give us a technique how to read ABG, like a step by step, step 1, step 2, step 3? Can we do that? Yes, we can. Pero kaya nga, before I will give you the technique how to read ABG, I discuss first briefly, okay, bird's eye view about what arterial blood gas is all about and its parameters. So that when we talk about ABG reading, hindi kayo nahihirapan because you have a background of or the theory behind it. Okay. So, Sir John, can you give me a step by step how to read ABG? Sure. So here's a step by step how to read the ABG. Okay. Oh, sorry. Steps. Okay. So the first step is to check the pH. Okay. So if you will encounter ABG values in your examination, your qualifying examination, the first step is to check the pH. Okay. We know the pH is 7.35 to 7.45, correct? And the mean is 7.40. And I mentioned that if the pH is high, okay, if the pH is high, we call that a sure alkaline. tuberculosis. Okay. And if the pH is low, okay, low pH, that is what we call acidosis. Simple as that. Okay. Next, the second step, okay, after you identify the pH, is to what? Identify whether it is respiratory or if it is metabolic. Okay, identify, after checking the pH, the second step is to identify whether that is respiratory in origin or respiratory in nature or metabolic in nature. So how will you know if it is respiratory? You will know it is respiratory if, okay, if, okay, the pH, okay, and PCO2 are actually opposite. Okay, you will know if it is metabolic if the pH and bicarb HCO3 are actually equal. Okay, equal. Now, sir, we already identified it's respiratory. We already identified it's metabolic. What is the third and the last step? The third and the last step is to categorize. Okay, so you need to categorize, okay, the category whether it is uncompensated, whether it is partially compensated, or whether it is fully compensated. Don't worry, I will give you an example later on. I think this is the part where a lot of nurses, okay, is actually having somehow confusion whether it's uncompensated, partially compensated, or fully compensated. Okay? So how will you know if it is uncompensated? How will you know if it is partially compensated? How will you know if it is fully compensated? Remember, I said a while ago that there are two systems that will affect the pH, correct? And what are those two systems? I said that, okay, you have your respiratory system and the other one is your urinary system. And I even mentioned that if one system is not functioning well, it's not doing well, the other system will help. The other system will compensate. In short, if the other system did not work, okay, didn't do anything, so that's uncompensated. But if the other system helped, pero failed to normalize the pH, again, if the other system helped, did something, but unfortunately, the pH did not normalize, that is partially compensated. But if the other system did something and the pH normalizes, that is fully compensated. Again, if the other system helped, did something, and the pH normalizes, that is fully compensated. Therefore, do not answer fully compensated if the pH is not normal. We call it fully compensated if the pH is normal. Okay, that's why we call it fully compensated. So this is the algorithm. Where's that? Okay. Uncompensated, diretso tayo sa partially compensated, fully compensated. Hold on. Message. What is this? Other people are watching you. Meg. Okay. That's fine. Yeah, I'm doing this for free, so doesn't matter. So by the way, if you want me to discuss other concept, just let me know. Okay. So here, let's begin with your respiratory. Uncompensated. Partially compensated. Here is your fully compensated. This is your pH. This is the PCO2 and the bicarbonate. So let's start with your respiratory acidosis. Okay? In respiratory acidosis, I said if it's acidotic, the pH is low, pH is low. And the relationship of your respiratory acidosis, PCO2 and pH opposite. Okay? Bicarb is normal. Partially compensated, PCO2 is high, okay? Bicarb is high. Fully compensated, pH is normal, PCO2 is high, bicarb is high. Now, I want you to listen carefully on this. Remember that the main problem of the patient is respiratory. So this is respiratory in nature. What did I tell you if it's respiratory problem? What system will compensate? What system will butt in? What system will help? It's your urinary. And what's the specific parameter here that will represent your urinary or metabolic? And that is your bicarb. Correct? I said that bicarbonate in nature is alkaline. And if it's alkaline, it neutralizes acidity. Look at you if it's uncompensated. The problem is respiratory acidosis. In short, there's too much carbon dioxide. Too much carbon dioxide called hypercapnia may be related to hypoventilation, causing a decrease in the pH. The problem there is there's an existing issue called respiratory acidosis, but bicarbonate did not do anything. Okay? Bicarbonate remained normal. The bicarbonate did not increase. Okay? So as a result, if the bicarbonate did not increase, the other system did not compensate. The other system did not try to help. Therefore, it is uncompensated. But if bicarbonate increases, okay, if bicarbonate increases, then that becomes partially compensated. Why did bicarbonate increase? Because bicarb is alkaline. Alkaline will neutralize acidity. The problem there is bicarb increases to neutralize acid, but unfortunately not enough to neutralize acidity to normalize pH. Tumulong siya pero hindi successful. Kaya nga partially compensated. Magiging fully compensated siya if the pH normalizes. Kaya tinawag fully compensated because successful ang pagtulong ng kabilang system, yung kabilang K structure. Remember the two structures, respi, and then you have your respi and then your urinary. So never answer fully compensated if the pH is not normal. It has to be normal to be fully compensated. Okay? I hope that's clear. Okay? May mga ibang lecturer, the technique is H technique, yung letter H, yung idadrag-drag mo siya to check acidotic ba, alkalotic, respiratory ba, metabolic. That is also okay. If you have techniques na alam nyo, nakasanayan nyo, that's fine. Okay? So ang point ko dito sa pag-stream is just to educate everybody why is this thing going on. Why do we call it partially? Why do we call it fully compensated? Okay? So at least this will somehow add to your this will add to the knowledge that you know. Okay? So again, this is your respiratory acidosis. Okay? Now, what about if it is respiratory alkalosis? Remember, respiratory alkalosis is common to patient who hyperventilate. Okay. So respiratory alkalosis. If this respiratory alkalosis, of course, there will be an increase in the pH, a decrease in the PCO2. An increase in the pH, a decrease in the PCO2. Remember, when you hyperventilate, you lose carbon dioxide, causing hypocapnia or a decreased carbon dioxide in the body. It is uncompensated if the bicarbonate remains normal. In short, the bicarb didn't do anything to help, didn't do anything to correct respiratory alkalosis. But if bicarbonate, sorry, napaburp bigla. But if the bicarbonate decreases, okay, if the bicarbonate decreases, but the pH remains abnormal, then that is partially compensated. Question, why did bicarbonate decrease? Because bicarb is a form of alkaline. The moment you increase bicarbonate, lalo ka pa maging alkalotic. So, ibig sabihin, the body will decrease bicarbonate because you are already alkalotic. Okay, you have to decrease bicarb because we're already alkalotic. The moment you increase bicarb, the more the patient becomes alkalotic. So we have to decrease bicarb. Unfortunately, even there is a decrease in the bicarbonate, the pH is still abnormal. The pH is still high. In short, ang pag-decrease ng bicarb, tumulong siya pero hindi successful. Partially compensated. But if bumaba yung bicarb, bumaba yung carbon dioxide, na normalize ang pH, that becomes fully compensated. Again, fully compensated because the pH normalizes. Okay? I hope this is clear. I hope this is clear. So this is your respiratory alkalosis uncompensated, respiratory alkalosis partially compensated, respiratory alkalosis fully compensated. Okay? Next, let's talk about metabolic. And then after this, I will give you a sample value, and then we will follow the steps. Okay, let's begin with your metabolic acidosis. Okay, metabolic acidosis. Acidosis, there's a decrease in the pH. Okay, bicarbonate decrease, PCO2 normal. Remember the relationship of these two? Equal. Remember, Romeo, metabolic equal. A decrease in the bicarb means there is no alkaline that will neutralize acidity. Okay, therefore, if nobody neutralizes acidity, you will end up having acidotic. Now, kanino common yung metabolic acidosis? To patient having diarrhea. Okay? If you have diarrhea, it can cause metabolic acidosis. This is uncompensated because the PCO2 did not do anything. It's still normal. But if the PCO2 decreases, bicarb decreases, pH decreases, in short, tumulong yung K, tumulong yung baga. Ang problema yung pagtulong niya na bumaba siya, hindi successful, may abnormality pa rin yung pH, so that becomes partially. Why did carbon dioxide decrease? Because a decrease in the carbon dioxide, okay, a decrease in the carbon dioxide will increase the pH. Remember, it can cause alkalosis. Okay, it can cause alkalosis. So, ibig sabihin, this is what we call partially compensated. But if the pH normalizes, PCO2 is low, bicarb is low, then this is fully compensated. Okay? Fully compensated. So this is metabolic acidosis uncompensated, metabolic acidosis partially compensated, metabolic acidosis fully compensated. Okay? Now, let's talk about metabolic, what do you call this? Alkalosis. Metabolic alkalosis. And then let's try to erase this. Okay. In metabolic alkalosis, there is an increase in the pH and an increase in the bicarb. PCO2 is normal. Okay? It becomes partially compensated if the PCO2 increases, but the pH remains abnormal. Okay? But if the pH normalizes and the PCO2 bicarb is high, that becomes fully compensated. Why? Tumulong yung PCO2 na tumaas siya and it normalizes the pH. So that becomes fully compensated. Okay? Actually, in the actual review, if you were my student, may binigay ako na algorithm na pattern. Okay? But that is only for my students sa review. This is just an overview of what we have. Okay? Now, if you can still remember this, please bear with my drawing. Ayan. Okay. Remember, when you vomit, uh, uh, the vomitus goes up. So vomitus goes up, it goes up, it goes up, it goes up. The pH, it causes alkalosis. Diba? When you vomit, what is the sound when you vomit? What's the sound when you throw up? Uh. Ayan. When you vomit, am I right? It sounds like that. Alkalosis. Alkalosis when you vomit. If you have diarrhea, pag nagtatae ka, pag may diarrhea ka, saan ba yung paglabas ng tae? Di ba pababa? If you have diarrhea, pababa yung tae. So pababa din yung pH. It causes acidosis. So even if you forget all this stuff, just look at the movement of these substances. When you throw up, okay, when you throw up, the vomit just goes up. If you have diarrhea, the poop goes down. Okay, same with the movement of the pH. I hope that's clear. Anyway, let me see if you have any questions. Okay, none so far. Good. So let's try to have this sample. Okay, here. So we have the pH, PCO2, and bicarbonate. 1, 2, 3, 4. Okay, let's say that the pH here is 7.50. Okay, and the PCO2, let's say the PCO2, 750 is high. PCO2, let's say this is 32, and bicarbonate is 24. And this one, let's say 7.32. And then here, let's say this normally is 35 to 45. Let's say it's 40. And then bicarbonate, let's say it's 20. Number 3, let's say this is 7.47. And then this, let's say this is 47. This is 28. Okay. Number 4, let's say this is 7.44. This is 45, 48. $28. What about this? 7.38. This is, let's say this is 32. Bicarbonate, let's say this is 20. And here, let's say this is 7.33. 35, 45. Let's say this is 47, 6. Let's say this is 20. Okay. Let's try to answer this. Okay, try to write your answer. Ay, biglang nawala. Sorry. There. I'll give you a few minutes. Oh, hold on. Tanggalin ko pala yung picture. Hindi nang babasa sa likod. There. Okay. I think everybody's ready. Let's try to check. Okay. So let's begin with the sample number 1. 7.50, the normal 7.35 to 7.45. So technically, this is high, correct? PCO2, normal is 35 to 45. Sa kanya, 32, mababa. Bicarbonate is 24, normal is 22 to 26. This is normal. So what is this? Okay, mababa yung PCO2, mataas yung pH, walang ginawa ang bicarb. So technically, what is this? Respiratory. What is the first step? The first step is checking the pH, correct? Remember, I said the first step is to check the pH. So what is the pH? Acid, alka. Of course, pag mataas yung pH, that is what we call alkalosis. So alam mo na it is already alkalosis. So pag may nakita kang acidosis dun sa option, then you have to eliminate that. That's not your answer because you know for the fact that it is alkalosis. The second step is to check whether or identify if it is respi or metabolic. How will you know if it is respi? It is respi because you will check the pH and the PCO2. And the pH PCO2 are opposite. You will know if it is metabolic if you check the pH and the okay, bicarbonate, and they are actually equal. So let's try to check pH and bicarb. pH bicarb, are they equal? No. pH is high, bicarb is normal. It cannot be because they have to be equal. So metabolic alkalosis cannot be. So look at your respi. pH, PCO2 opposite. pH, PCO2, are they opposite? Yes, pasok sa banga. Therefore, you know it is respiratory alkalosis. You categorize, is it uncom, partially, fully? If it is respiratory, the other system should help. The problem is the bicarbonate didn't do anything. It's still normal. Hindi siya tumulong. And then what is that? It is uncompensated. So in number one, this is respiratory alkalosis uncompensated. I hope you got it correctly. Look at your number two. 7.32. 7.32 is low because the normal is 7.35 to 7.45. Okay? PCO2 is 35 to 45. Sa kanya is 40. Therefore, that's normal. Bicarbonate is 20. The normal is 22 to 26. It's low. Okay? So what is the first step? Check the pH. What is the pH? Mababa. So what is mababang pH? We call that a sure acidosis. So we know that this is already acidosis. So eliminate alkalosis in the options. So we know it's already acidotic. The second step is to identify if it is respi or metabolic. So let's check respi. If it's respi, check for pH and PCO2. They must be opposite. Are they opposite? No. One is normal, the other one is low. It cannot be. Look for metabolic. If it's metabolic, pH, pH, and bicarb, they should be what? Equal. Are they equal? Yes. Pasok sa banga. Therefore, we know it is metabolic acidosis. But what type of metabolic acidosis? Uncom, partially, fully. Look at your PCO2. PCO2 is normal. The PCO2 didn't do anything to help. Therefore, it is uncompensated. Uncompensated. So again, number two is metabolic acidosis uncompensated. Okay? Look at your number three. Number three, pH is 7.47. A 7.47 is actually high. Okay? 47, what is 47? High or low? High, because normal is 35 to 45. Next, bicarb, 28. It is also high. Why? Because normal is 22 to 26. So a pH of 7.47, we know that this is what? This is alkalosis. Alkalosis. So eliminate acidosis in the option because we know it's alkalosis. Second step, identify if it's respi or metabolic. Respi, the pH and the PCO2 must be equal. pH and the PCO2 must be, okay, not equal, must be opposite, sorry. Okay, these two must be opposite if you suspect respi. Unfortunately, they're not opposite, they're equal. So we cannot use respi. Look at your bicarbonate, it's increased, pH is increased. So this K pattern is okay, swak na swak for your metabolic because they are equal. So this is a form of metabolic alkalosis. What type? Uncom, partially, or fully? Remember, the PCO2 increases, trying to help. Unfortunately, PCO2 increased to help but failed to normalize the pH. Hindi successful yung pagtulong niya. How will you know successful? If the pH normalizes. So this is a form of partially compensated. Okay? So number three is metabolic alkalosis partially compensated. Okay? Next, number four. 744. 7.44 is normal. Okay? 48. Okay? 48. What is 48 for your PCO2, high or low? Normal is 35 to 45. It's high. Look at your 28 bicarbonate. Normal is 20 to 26. It's high. Okay? So what is this, Sir John? The pH is normal, but the PCO2 and bicarb are abnormal. So this is not a normal ABG, correct? And what did it tell you about the pH? Normal pH is 7.35 to 7.45, and the mean is 7.40. This is the mean. So this is now where your mean be very helpful. Remember, I said don't forget 7.40 because that will be your mean, okay, to check whether what type of full compensation it is. 7.44 is higher than the mean or lower than the mean? 7.44 is higher than the mean. The mean is 7.40. Sa kanya is 7.44. Pero alam natin that this is normal. 7.44 is normal but higher than the mean. So we use this higher than the mean. So increase is what? Acid alka. That is alkalosis. Okay? Check pH and PCO2. If it is respite, these two must be opposite. Are they opposite? No. Okay? They're actually equal. Hindi pwede. Look at your bicarb. Bicarb is high. pH is normal but higher than the mean. So pasok siya. So this will be metabolic alkalosis. What type? Uncom, partially, fully. It is fully compensated because the pH is normal. So this is fully compensated. That is why it's important for you to know that 7.40, the mean, is powerful for your examination. Okay? Pero alam natin that 7.44 is normal. Okay? Next. Number 5, 7.38. Normal is 7.35 to 7.45. Again, this is normal. 32, this is actually low. 20, this is actually low. So we cannot say that this is a normal ABG. There is something wrong here, correct? So the first thing to do again is to check the pH. Is the pH normal? Yes. Is the value of the pH higher than the mean or lower than the mean? Lower than the mean. Lower than the mean, low pH. So we call that as your acidosis. But again, is it respi or metabolic? If it is respi, the pH and the PCO2 must be opposite. It cannot be kasi pareho silang decrease. If it is metabolic, the pH and the bicarbonate must be equal. Equal ba? Yes. So this will be metabolic acidosis. What type? Uncom, partially, or okay, fully compensated. Again, this is fully compensated. Why fully compensated? Because the pH normalizes. So again, number 5 is metabolic acidosis fully compensated. Next, number 7. Number 7 is 7.33. 7.33 is low. Okay? PCO2 of 47, 47 is high. Bicarb of 20, 20 is low. Okay? Again, this is not a normal ABG. So what is the first step? The first step is what? Check the pH. What is the pH? Low. And what is low? That is acidosis. What type of acidosis? Let's check. Is it respi? Is it metabolic? If it is respi, the pH and the PCO2 must be opposite. The pH and the PCO2 must be opposite. Pasok ba siya? Pasok. Therefore, this is respiratory acidosis. But it doesn't end there. Look at your metabolic. Pag metabolic, pH and the bicarb must be equal. pH and the bicarb equal. Pasok din ba siya? Pasok. So, it is also metabolic acidosis. So, what is this number 7? Number 7, ang reading niya, interpretation is mixed respiratory metabolic acidosis. Mixed respiratory metabolic acidosis. That is the answer for number 7. I hope you learned something, guys. Ayan. Okay, so that's it. Okay, so that ends my concept. I hope you learned something. I hope this will be useful. If you know ABG, if you master ABG, I hope may natutunan kayo sa ating presentation. Just let me know what topic you want me to present tomorrow. Maybe tomorrow morning. Tomorrow morning, that will be nighttime in the Philippines. Okay, so if you have any questions, let me know. Kung wala, okay lang din. Okay. Okay. Journal how to enroll. Oh my God. Actually, I really don't know the process of the enrollment, but if I were you, you better check the website. It's www.usreviewcenter.com. usreviewcenter.com. So what time to start? I still don't know because it's 1 o'clock in the morning here in the US. I will sleep after this. Magmuni-muni, sleep paggising. Hindi ko alam pa nung oras, but definitely I will have a class tomorrow. I still don't know what time, but I will just keep posted. By the way, what do you want me to discuss tomorrow? Any topic you want me to talk about? Or ECG? Okay. So I will talk about ECG later pagising ko. So sa ECG, we'll talk about the physiology of conduction system, uh, tracing, and pharmacology. Okay. So we'll talk about the tracing. I'll give you the tracing and then what medication will be given to your patient. Sinus tachy, what is the drug of choice? Sinus brady, what is the drug of choice? AFib, what medication will be given? A-flutter, what medication? Okay. PVC, what medication? First degree AV block, second degree AV block, Mobitz 1, Mobitz 2, third degree AV block, what medication? So that will be my approach tomorrow. Okay. Sir, sorry, di ko na-catch what time you will start tomorrow. I still don't know. But definitely, I will have my class. Don't worry, I will not delete this one. So, para ma-view nyo pa rin. Okay? So, thank you so much, guys, for staying. I hope you learned something. God bless and yeah, keep safe, everybody. Okay? Bye for now.